I'd like to welcome everyone to the 5th Annual Patients Redefining the Future of Healthcare in Canada Summit. And I'd like to invite Margaret Peters and Jennifer Graham to turn their video on and unmute and get us started for the day.
Sorry, Leah, they won't let me start my video.
Okay, I think
it says a co-host
it is working. You're on.
Okay.
Great, welcome.
Sorry about that. So thank you everyone for attending the third session of Patients Redefining the Future of Healthcare in Canada Summit. Today we are focusing on value-based healthcare. I'm honored actually to be co-presenting with Jennifer Graham. She's done unbelievable work, and so I'm really humbled to be with her. I'm Margaret Peters. I'm founder of the Unmasking Psoriasis in Saskatchewan to educate and assist people living with psoriasis. And Jennifer is with Congenital Health. And so I'm looking forward to hearing the panelists and an exciting day. I'll pass it to Jennifer.
Thank you, Margaret, for that introduction. So as Margaret already mentioned, we're going to be talking a lot about different work initiatives and working groups over the past year. So we're going to start off with value-based healthcare. This is the first session today, and we just want to remind everybody of basically what the simple definition of value is from Porter and Teisberg, and that is that outcomes that matter to patients. And value can be achieved in several different ways. This includes improving outcomes that matter to patients or decreasing costs to deliver those outcomes across the care cycle. There are three major enablers of value-based healthcare. First one is a focus on population segments. Second is population-specific integrated models of care, and population-specific patient-reported outcome measures. All of these enablers require a supportive policy environment, and the integrated models of care require specific policy changes, including those related to payment systems that incentivize value and end incentives to achieving value, like volume-driven payments such as fee for service. PROMs require necessary resources and capacity related to data and interoperable informatics that protect, respect, and fulfill personal health data rates. And it's no surprise that after last year's 2019 summit, our patient and caregiver participants decided to form 3 working groups focused on integrated models of care, PROMs, and data.
Okay, today's agenda. Today we're going to work with the 3 groups, which will be working groups, and we'll be reporting back on our efforts and progress over the past year to the November summit in 2019. Jennifer and I are going to be reporting back to you on the integrated health models of care working groups. Then we're pleased to have Scott Wolf, who will be presenting it to you an example of integrated models of primary healthcare that our group identified through its scanning and surveying process. Next, Ava Villabra will report back on the PROMs working groups. Chanel Patka will report back with the data working groups. We'll have a moderated Q&A session with Leah, followed by a break with mindful meditation. We are excited to have Monica Slovak DeAngelo of Value-Based Healthcare moderate a panel of stakeholders from government and data governance to comment on what they have heard from the working groups and where they see the opportunities to grow such value-based healthcare initiatives across different jurisdictions in Canada. Finally, we will move to the breakout groups as we've done over the last 2 days. Please go to the same group that you've been using until now. You can find the list of breakout groups in the lobby if today is your first day. Thank you again for joining us on this.
Thanks, Margaret. So now I'm just going to briefly go over a high-level summary of what the Integrated Models of Care Working Group worked on. So our first task, that we agreed on, was our purpose as a group and what we considered important in thinking about integration. Our focus this year was on identifying and examining integrated models of care that integrate physical and mental health, determinants of health, equity, cultural safety, and trauma-informed care, including Indigenous specific models. And you can see below on the slides is basically our purpose and overarching structure for the working group. And before I move on to what we did next, I want to take a moment to acknowledge everyone who worked so hard in our working group this year. And the names are listed here. We have Johanka McPhee from Mental Health Advocate, Louise Binder, Save Your Skin Foundation, John Sodden from Cardiac Health Foundation, Ella Amir from AMI Quebec, Elizabeth Bono, Joanne Ticknor from MS Society Canada, myself, and Margaret, Evans Yellow Old Woman from the Alex Community Health Center, Dr. Ambreen Sayan, clinician researcher, and then of course Leah, our backbone and support for the group. Okay.
Sorry, I forgot to unmute. Next, we're going to do a brief scan to get on the same page about what we meant by integrated healthcare models. We found a great deal of alignment with the World Health Organization integrating people-centered healthcare services framework. We sent to everyone registered for the summit a short pre-read document that outlines a framework that we developed for ourselves, including our definition of the integrated models of care, as well as the strategies that support person-centered integrated models of care and different types of tactics that implement these strategies. For full details, please review the short document we sent you as a pre-read, because there are too many tactics to name right now, and they are all important little tidbits that you can pick up in it. Go ahead, Jennifer.
It wasn't switching. Okay, for the next, we brainstormed examples that we knew of that would fit the framework we had identified and agreed upon as a group. We then ran a survey to determine whether or not they did indeed meet our definition, strategies, and some of the tactics associated with integrated models of care. We found numerous examples from community health centers as well as Indigenous specific models. We also found 2 promising international examples listed here, but we decided to focus on Canadian examples today. And on behalf of the entire group, I want to thank all of the healthcare providers that took the time to complete our survey. We recognize that their time and energy is limited, and they work so incredibly hard to address the impacts of COVID-19 on the people that they serve. So thank you.
Okay, the introduction. Before I introduce our speaker, I'd like to point out a few examples of the integrated models of care that we identified, called community health centers, are integrated person-centered primary healthcare models. Some of them do span the broader array of care continuums, but not all. All of them have the role of providing integrated, professional primary health care for key populations for birth until death, and ensuring seamless care coordination and system navigation between primary health care and all other parts of the health and social services system that people will require various times in points of their lives. Now, I am pleased to introduce Scott Wolf. Scott Wolf is Executive Director of the Canadian Association of Community Health Centres, where he is responsible for the association's overall operational management. The association works with community health centers across the country on various research, policy, healthcare services, and advocacy initiatives aimed at improving access to appropriate healthcare and social services for all residents of Canada. Scott is also coordinator for International Federation of Community Health Centres, whose secretariat is based in Toronto at the Canadian Association of Community Health Centres. Prior to joining CCHA in 2010, Scott was social policy advisor from 2004 to 2008 for the Alliance of Healthier Communities, formerly Association of Ontario Health Centres, during which time Ontario networks of community health centres doubled in number and reach throughout the province. He also served as previously as Director of Global Health Policy for the International Association of Providers in AIDS Care and Communication Advisor for Pan America Health Organization, World Health Organization. And Scott lives in Toronto with his partner and 3 children. Thank you so much for fitting us in, Scott, and welcome.
There we are. Hi, everyone. Thank you very much for the very kind introduction and the generous invitation from the organizers to present today. Pardon me as I try to get this. There we go. It's just a bit of a lag. I hope you can all see me and the first slide here in my deck. Yeah, so I'd like to first thank the organizers, not only for all of your work in putting together the conference this week, but also for the invitation to myself and the Canadian Association of Community Health Centres to speak to participants. I hope you've had valuable sessions so far, and I hope I can contribute some additional value. I see this as a conversation, and I look forward to the opportunity to work with organizers, with members of your working group on integrated models of care moving forward to see how and where we might collaborate. And I provide my contact information there via Twitter and at the end via email. I'm open to questions if you have any ongoing questions moving forward, or would like to explore opportunities for collaboration, be it at the national level or more regionally. Before I jump in, I'd just like to talk about context internationally as well. I think I focused my slides and most of my comments on the Canadian context, but as you heard in that very generous introduction, we also at the Canadian Association of Community Health Centres house a very small, emergent international federation of community health centres, which speaks to the fact that this model of care has taken root in many, many places around the world. In terms of its global history, and I'll tell you more about the community health center model for those of you who are just hearing about it for the first time. It dates back actually over a century. The first instances that we're aware of something that we would today qualify or consider a community health center, took root at approximately the same time in China, South Africa, and Canada. In 1926, the first community health center in Canada was established in Winnipeg, Mount Carmel Clinic, which was established by the Jewish community in that city, which was really taking into its own charge the need to provide services to an influx of immigrants to the city who are coming for work and who are being excluded from services within the community. The Mount Carmel Clinic was established in 1926. In the 1920s as well, via the John D. Rockefeller Foundation at the University of Beijing, another example of a community health center was established. And very shortly thereafter, in the community of Folela, a rural community in KwaZulu-Natal, South Africa, the Folela Community Health Center was established by a physician couple who was working in the local community to integrate care and base services not just on medical need, but a wide range of social factors as well. We have information and stories about that global picture at the International Federation of Community Health Centers, ifchc.org, if you're interested in learning more about the global picture. And I'd be happy to share some of that information afterwards. All to say that I feel the community health center model, and again I'll get into this, one that has a certain inherent virtue to it, which has led a variety of people working in isolation from each other in very, very different contexts to arrive at the same point, which is really the provision of an integrated array of services based in the community with community input, and that address not just medical needs, but really the lived social realities of a local community. Community health centers around the world go by many different names. They're not always called community health centers. In the United States, we have a network of over 12,000 community health centers that provide services to over 23 million Americans. In South Africa as well, there are community health centers in Belgium, in the Netherlands, in Thailand, in Francophone West Africa, and onward. You'll find examples of community health centers. And so I think it's helpful to start from that global perspective and say that, you know, there's something inherent in the idea of a community health center, and some of what I'll talk to you about in terms of what characterizes a health center that has, you know, come to be in many, many different places around the world as people grapple with the challenges of not only how to provide accessible healthcare services, but how to build health, how to build healthy communities, and how to improve health outcomes for individuals, families, and groups. So let me move to the next slide. There we go. You know, as I was initially reflecting on the idea of integrated models of care, and, you know, took note that the working group was drawing from the work of WHO, caused me to reflect on the fact that at about the same time, the conversation related to integrated people-centered health services has been part of a broader trend I've seen over the past few years to really bring to fore the idea of taking a system approach to the integration of services and policies that work to overcome silos and barriers and take a holistic approach to how it is we improve delivery of services, but also how we build healthier societies. And so the IMOC movement that's kind of grounded in integrated people-centered health services has something kindred with the social development, sustainable development goals that are being advanced by the United Nations, as well as the idea of primary health care itself, which is being advanced by WHO. And so this conversation, I feel, is at this particular time in history, while is long overdue, feels to have some momentum behind it. And there are themes that seem to be taking hold in different parts of our global networks and frameworks that I hope ultimately will help to push this over sort of the tipping point to a point where more governments globally, and certainly here in Canada, governments are moving to the sort of integrated systems that we that we need. And and so you as allies, we all, and the working group on integrated models of care will have a bit more fertile ground through which to do our advocacy over the coming months and years. So community health centers differ across our country in size, scope of services, types of funding, and often name, by virtue of the fact that we live in a decentralized federation where not only are responsibilities for planning healthcare the responsibility, of multiple jurisdictions of each of the provinces, as well as the federal government with respect to certain populations. But also that, all of those provinces and other jurisdictions have gone about advancing primary care in different ways, and have, to certain degrees, chosen to support the idea of integrating primary care services with the other types of social supports that we know are equally, if not more important to health outcomes of individuals, groups, and communities at large. So we as an association have had the challenge over the last decade or more of really trying to bring some coherence to this network and movement that we capture under the umbrella of, in the name of, community health centers, understanding that there's a wide variation in terms of what that actually looks like on the ground, from one community to the next, and from one province and territory to the next. And I've come up with a way of capturing that, so we know really what does fit into that network and that sort of that model, and what we can consider a community health center, and what is outside of that model. It's not to say that we believe that community health centers are the only way to go about delivering, primary care services. But as you can imagine, with so many other types of models, we have to have some sort of sense of what's in and what's out, and what is a community health center and what isn't. And so we've arrived at a definition across Canada that helps us to do that, and helps us to work with community organizations that maybe are a community health center but have never truly understood themselves as that, or might be on the verge of becoming a community health center. And what's entailed in that definition, as you see here, is that these are multi-sector health and healthcare organizations that integrate services, and that they adhere to the following 5 domains. That they deliver interprofessional primary care, meaning that not exclusively primary care delivered by physicians or by nurse practitioners, that it may be one or both in combination with other care providers. We don't define in our definition any more about those providers that, for instance, they all must be paid by salary, or they all must operate according to a certain type of modality, because that's often out of the control of community health centers themselves, and is the subject of provincial or regional health authority policy. And I'll touch on that towards the end of my presentation in terms of opportunities for advocacy. But really, it's just to say that To deliver effective primary care and to be considered a community health center, we believe that it really is a team dynamic where an individual entering into the circle of care at a community health center will have access to more than one, generally more than 2 or 3 types of providers. That will include, as I said, family physicians, nurse practitioners, nurses, occupational therapists, physiotherapists, social workers, counselors, and so on. The second is that whatever those primary care services look like, they're integrated within the organization with health promotion and community well-being and development programs. That means that it's not just about what happens in the clinic, it's also about people's lives and realities outside of the clinic. And that in order to really wrap services and care and support around people, we have to be able to be in the community, and we have to be able to deliver support programs and look at the factors in the community that have an impact on health, if that's levels of poverty, levels of education, and so forth. So really that second one is about the integration across sectors. The third is that it's community centered. What that means is having a community board of directors. So community health centers across the country are not-for-profit organizations, which are operated as not-for-profit corporations or as cooperatives. That means that they are independent from, have autonomy from government, are typically funded by government, but in terms of the accountability, the planning of services, and in terms of making sure that as organizations, they are responsive to the local realities and needs within a community. They are governed by a board of directors that is comprised of representatives from the community and from the region. It's usually a mixture of skills on that board, as well as representatives from the local community. You can speak to the local needs. Then the fourth characteristic is really addressing social determinants of health in an active way. I touched in the second point on the need to really look at the social factors. This really means that at the level of services, at the level of advocacy in the local community, and maybe at the bigger picture of municipal level, provincial level, national level, that the community health center is mindful of and attuned to social factors that have an impact on health. So that various forms of social exclusion, for instance, and anti-oppression, be that racism, be it marginalization based on sexual identity, gender, other demographic and identifying factors. It can be housing and lack of access to affordable housing, poverty, education, that myriad of social factors that really is the 80% or more of what contributes to health or detracts from health that's really under the surface. If you think of the iceberg, primary care and the actual services are that 10 to 20% of what can impact health above the surface. That 80% below the surface are really all of the lived realities day to day that have an impact on our health. And so community health centers address these in an active way through policy and advocacy and through direct services and programs. And really, taking that up to a systemic level, the last point is taking action on health equity and social justice. It's recognizing that not only are these factors that impact individuals, but there are systems at play that perpetuate those negative factors, those factors that negatively impact health, and that it's the role of a community health center to really take a system approach and to address those inequities through through more of a system approach and through a commitment to social justice. So that, in a nutshell, really is what are the filters and the lens through which we would look at an organization and say, yes, it is a community health center. Now, I spoke to the idea of intersectoral integration. What does that actually look like on the ground? Well, the latest national survey that we did of community health centers, and we're due for another survey to get an update on statistics like this, but that we did in 2016, sought to identify the number of sectors in which CHCs are delivering programs and services actively. So this is through the community health center itself. In addition to direct services, CHCs will work in partnership with local agencies, et cetera. But this question sought to capture in how many sectors, such as senior services, primary care, housing and homelessness, reduction, income support, working in the judicial system, et cetera, in how many of those sectors that we could identify based on sort of a comparator of how governments identify sectors at the federal level and at provincial levels. How many sectors are they actively offering services in? And we found that what is it there, that 78, confused by the color scheme for a moment, that 78% of community health centers were actually providing active services and programs in more than 6 sectors. So again, primary care, housing, food security, so forth and so on. I do have information that actually breaks down the extent to which community health centers are active in that variety of sectors, but it goes to show you that the overwhelming majority, 78%, are active in more than 6 sectors. 100% of community health centers are active in more than 2 sectors, which comes back to the definition, as I shared it with you just a moment ago, that if an organization is exclusively providing primary care services, even if it's doing so through a team of care providers working across disciplines, that alone would not characterize an organization as a community health center. And that's important to note because there has been a lot of progress across the country in advancing team-based care. You'll find that almost every provincial government, almost every territory, if not all of them, have some sort of active program to advance team-based care, recognizing that it's important to provide individuals and families teams of providers where you get the right care at the right time by the right provider. And that's progress, but far too frequently, that team-based care is decoupled from health promotion, community development, all of the other areas, sectors of activity where we believe it's critical to have touch points and to integrate with. Because if we don't do that, we're again missing so much below the surface of what actually contributes to what an individual is presenting with in clinic. And it provides an inadequate picture if you're just looking at the clinical setting of what the best remedies are to actually help an individual on their path to well-being. So the integrated nature of services across sectors is critical. Now, that's all fine at the level of an organization. You get a general sense. What does that look like from, an individual client's perspective? We have, various stories on our websites and issue-specific stories, I think, are available from individual community health centers. And I'd be happy to share more of those. But I thought it'd be useful in the background materials for this session, for the conference, to share an example of a story. I hope that all of you have access to the background materials, but just in case, and just to sort of walk through a personal story of one individual's encounter with the community health center, I thought I would share with you Bernie's story. And I'm just going to read it from the background. For those of you who accessed this already and have read it, my apologies for the duplication. But I think for those who haven't had access to this case study or story, gives a bit more of a practical sense of what it means to be in contact with a community health center. And my apologies, I'm looking down because I'm reading it to you. So Bernie's an Indigenous senior in Edmonton, Alberta, who first came into contact with the Boyle-McCully Health Center through the Community Health Center's Mio-Waiawin Clinic. The clinic is a service provided by a Boyle-McCully Health Center on site at a local partner agency, the Edmonton Native Healing Center. Bernie first accessed the center's foot care program, and he did so for the first time in 2016. After having the wound on his foot attended to, he became a regular at the foot care program and gradually became comfortable enough to talk a bit more openly with Donna, one of the community health center's nurses. Bernie had been homeless, living on the streets for 6 years. He had multiple chronic illnesses, including diabetes and heart disease. He was having challenges controlling his alcohol use, and he had no access to routine primary care. Building on the trust that Donna had established with Bernie, she connected him with Sandy, one of the community health center's nurse practitioners, from whom Bernie now receives regular primary care. Sandy also referred Bernie to an ophthalmologist, and he's had cataract surgery as a result. Bernie has also been referred to a detox program, and at the point of writing this, and I truly hope that this remains the case for Bernie's well-being, at the point of writing this, he was many months sober. Through Boyle-McCully Health Center, Bernie has also been connected to permanent housing with an inner city seniors housing program. And as a regular client of multiple other services provided by Boyle-McCully Health Center, Bernie's at the center of a circle of care and one of support that's there for him when and hopefully where he needs it. Now moving on to more generally about Boyle-McCully Health Center in Edmonton, their 13,000 plus clients, those that access services and programs at the Community Health Center, have access to wraparound care through an interprofessional team. This means chronic disease management, mental illness and addictions care, HIV care, hepatitis C care. All of those, for example, are integrated as part of regular primary healthcare services. The care team is comprised of nurse practitioners, nurses, social workers, family doctors, psychiatrists, mental health and addiction counselors, dentists, and outreach workers who work together with Boyle-McCully's clients to address their needs at the right time and by the right providers. They also have a dedicated health advocate on staff, and the health advocate acts as a resource for both the staff and clients at the center in regard to housing, financial and legal issues, food and clothing issues, educational and employment opportunities, applications for government assistance, and more. In addition to Boyle-McCully's health advocate, social workers play an essential role. Social workers are always on site at the Community Health Center's main location and are always able to help line someone up with services or to help them navigate services from a government agency or another social service agency in the community. If a client needs help with income tax as part of addressing poverty or low income, for example, the health advocate connects the client to a volunteer who can help with that. If a client is interested in finding work or going back to school, Boyle-McCully Health Center provides support for resume writing, mock job interviews, and other support tools. And as needed, Boyle-McCully Health Center will work with its clients on government assistance to establish third-party payment plans in order to guarantee that a client's rent get paid when benefits check goes out, or other forms of support to mitigate the chance that someone will remain or become precariously housed or homeless. There are other examples that go further into detail on the programs at Boyle-McCully Health Center within that case study. I'll stop there just to give you a flavor of what that looks like from the individual perspective. But that's one story of a single client at Boyle McCully Health Center in Edmonton. What I'd say in addition, just to bring that back up to the level of community health centers more generally across Canada, is that you'll find that same sort of texture of personal support and personalized care within the scheme of the organization's services that's provided to individuals, families, and on occasion groups as well. Highly tailored to the realities in a local community. We often say that when you've seen one community health center, you've seen one community health center, meaning that there is a common theme and characteristics, as I pointed out, but that they really will, through support of their community-based board of directors and their multi-professional diverse staff, really attune the services and programs they deliver to what they're seeing in the local community. Now, COVID-19 provided us another opportunity to see how community health centers work at the local level, being nimble and adaptive in the face of emerging issues and quite complex issues. We conducted research during the early months of the summer just to find how community health centers had managed through the pandemic and what experiences they'd seen at the level of their patient client groups and what they'd done in response. We're really not surprised, I guess, but very encouraged to see that that 100% over the first few months of the pandemic, 100% of community health centers across the country who responded to the survey, and it was a high percentage who did respond, were doing outreach in the community to help provide information about what COVID-19 is, preventive measures, how to access services, and what to do in the event of local business closures, school closures, and so forth. Again, in this very emergent phase of the pandemic, 58% of community health centers across the country had pivoted in order to either operate an assessment center, operate as an assessment center to provide testing, or participating in local assessment and testing initiatives. And a very impressive number, 95% over the first few months, had been able to pivot and were now offering some scope of their ongoing services virtually. All of this points to the impact of community health centers in ensuring continuity of care. Obviously, there are certain enabling factors at community health centers that provided for their ability to do that pivot and to be able to ensure continuity of care. Some had resources at their discretion to invest in personal protective equipment, to retrofit their buildings, to go online, whereas others didn't. They may not have the funding. There may be barriers locally, such as lack of access to broadband internet service, which provided a challenge when it comes to providing services locally. But I think these stats demonstrate that community health centers were able to pivot fairly effectively, fairly broadly in terms of rising to the challenges of COVID-19. And you would have seen other examples of this sort of responsiveness more locally in Alberta, for instance, in Calgary during the floods several years ago, in Quebec many years ago during the ice storms, and again in Ottawa more recently during the ice storms that led to massive power outages and shutdowns of businesses and services for several days. And so it is that ability to be nimble, to have some organizational capacity to react and respond to emerging issues that adds value at a regional level of having a community health center where individual providers, individual and group practices of physicians and other care providers may not be able to do that because they don't have that administrative organizational capacity.
Hey, Scott, sorry to interrupt. I know you still have some good content to get through, but if you could, we're just at the end of your time. I don't want to shortchange anyone else. Thank you.
I absolutely will. Thanks, Leah. You'll have access to my slides. So I think this is more, again, more evidence of that impact of continuity of services. So I'll just leave that up for a moment and roll to the next slide. This is from one community health center, again, in Northwest Ontario, Norwest Community Health Centers, an example of this sorts of social services and supports that the center was able to pull together with a small $5,000 grant that we were able to facilitate for them in partnership with TD Bank's Ready Commitment, who provided a national donation to community health centers to do this sort of work. And it gives you a sense of the sorts of daily needs that a community health center can respond to, in addition to their ongoing programs when an emergent situation poses challenges to individuals who are often, you know, in precarious work situations, inadequately housed, living check to check, and you know, for whom having access to a bag of groceries can mean the difference between having children go hungry for, you know, a week or not. So again, you'll be able to come back to this slide, and we have more stories and cases at this website where we have a few videos, blog stories that tell stories from the front lines, as well as news articles that are curated there, if you want to get a bit more of a sense of the impact of community health centers during the pandemic. Now, again, I'm glad, since we're running close to time, that I touched on most of this sort of in the introduction. That community health centers are highly divergent across the country, not in terms of vision, mission, and goals, but really in terms of what they're able to accomplish based on the realities of our very fragmented healthcare system, the fact that at a policy and funding level, we're at a place where, despite the conversations that we are having here, and despite, I think, what patients know very well and want from their services, where healthcare is in reality dislocated from other sectors of services when it comes to how they're funded, who plans them, and so forth. And we have we still exist in a paradigm where curative medical services dominate. And so community health centers, despite their differences, are all sort of reactions and responses to the inadequacy of all of these barriers, silos, and fragmented systems, and are doing their best within the scope of, within the context of their local province, and within our national context to respond effectively to that. However, that requires responsive governments, and it requires the types of supports that enable the type of services that I described in Edmonton at the Boyle McCulley Health Service Center, the ones that Bernie was able to access, and many other individuals who access Boyle McCulley, for example, are able to access. So, you know, as I said, again, you know, these are examples of the challenges that we face, that most provinces and territories don't have any official policy or guidance for community health centers. There are some examples. For instance, Ontario and British Columbia actually have policies. They have provincial programs for what community health centers should look like, how they should be funded, and so forth. A large majority of community health centers don't receive core funding for their overall work. Some don't receive any government funding at all. They truly are grassroots local organizations that are patching together services through grants, through individual provider contracts, and so forth. And where core funding exists, and this is increasingly so even in leading provinces like Ontario and and the city of Winnipeg, for instance, there's an increasing focus on just primary care and erosion of, you know, all of those other complementary services and programs and the funding for those that that's so essential in terms of contributing to health and well-being, particularly for individuals who face complex social and medical realities. And lastly, there just simply are far too few communities that have access to any type of community health centers. So those are some of the systemic and structural barriers. Now, my final slide, I'm almost there. What does that mean in terms of our forward-looking vision, and what it is that we can all look to achieve together and focus on together? Well, it really is to call on governments, both individually, so the individual provincial government, federal government, and municipal government, to think about funding services from a cross-sectoral perspective, but also to work across levels, because as you can imagine, community health centers, as very dynamic organizations, are doing work that falls under the jurisdictional responsibility of all of those levels of government. And so community health centers are making real on the ground the integration of services. That's very hard to accomplish when the policies and the types of funding that are available are a barrier to doing that. And so we need governments to think about operating from an intersectoral perspective, and we need to call on them to do so. It really means that, again, the policy and investments should facilitate that and provide organizations with some administrative capacity themselves to navigate systems, but to support clients to navigate systems. And so that's what I mean in the second bullet there about having administrative and navigational capacity. Your family physician's office, even if it's a group practice, just doesn't have that sort of capacity to be helping clients who may be diabetic and require an adjustment to diet, but are living in poverty, figure out how they do that. And so we need organizational capacity to help clients find their way to food security programs and all of those other services that can help mitigate negative lived realities and to help overcome them. We also need, systemically in partnership with academic partners, but also looking at our partnerships with federal funders to really draw attention to measuring what matters. Are we just measuring procedures when it comes to primary care, for example, or to someone's access to a particular program or service, or are we measuring outcomes? And so we need a research agenda. We need an evaluation agenda that really focus on what matters. And that's what matters to people for their own health. But it's also assessing, whether in fact they, are progressing along a path of well-being. And my very last point really is that this can't be strictly top-down in terms of how we fund services for whom and where they're needed. We need community engagement. We need participation of individuals as clients of services. You notice I haven't used the language patient much. In the community health center sector, we tend to use the language of client, but what I mean essentially is consumers, clients, patients of services having an active role in providing input and feedback, and helping shape services through client engagement surveys, advisory panels, et cetera, but also at the level of governance. That we need that level of participation in terms of our services, not just primary care services, but our broader social services, to make sure that they really are attuned to local needs, that they are attuned to what people in the community want, and that they aren't static, because communities aren't static, communities evolve. And so having that participation enables community health centers to evolve over time as communities evolve. So I hope that resonated. I'm again happy to participate in Q&A and moving forward, invite ongoing collaboration to see if we can't move forward some of these policy and advocacy points that I think are in our collective best
So
interest.
we will be in touch, Scott. Thank you very much for that presentation.
And there I am. And thanks so
Excellent. Thank you very much. And just to encourage everyone, don't forget to tweet out some of these great ideas, hashtag patients redefining healthcare. And please do enter your questions as they arise in the Q&A box for when we get there. We are running a little over time, but don't worry, we'll catch it up in the break if need be. That was a lot of important content. Thank you very much, Scott. Now I'm going to move us immediately to our next presenter. I'd love to introduce Eva Villalba, the Executive Director of the Coalition Priorité Cancer au Québec. Eva is the chair of the Patient-Reported Outcome Measures, or PROMS, working group. Over to you, Eva. Thank you so much.
Hi, everyone. Happy to be with you today virtually. So let's get right into it. We had, following last year's Patients Redefining Healthcare Summit, we created a working group on PROMS. And so today I'll present basically one of our conclusions, which is how patient advocacy groups in particular can contribute to developing PROMS for their specific populations. So we've been talking about value-based healthcare, and as it is with many emerging trends, there's lots of acronyms and jargon thrown around. So I'd like to start with defining what are patient-reported outcomes, what are PROMS, patient-reported outcome measures, and why should you care? So outcomes are basically results, and health outcomes are the results of care. Patient-reported outcomes measures are the tools that we use to measure those outcomes. And why is this important? Because historically, we have measured things in the healthcare system, but it's been mostly clinical outcomes like progression-free survival or process metrics like delays in treatment or diagnosis, but less so from the point of view of the patient. And so PROMS, or patient-reported outcome measures, are really instruments that provide information about the aspect of patients' health status that's relevant to their quality of life. So the quality of life has really been a factor that we haven't looked at so much. It's kind of seen as a bonus or a nice to have, but not an essential part. And really specifically about their functionality and their physical, mental, and social health as well. So what's the real world application? Why should you care? and how do we do this in the real life? So patient-reported outcomes are actually essential to understanding if the healthcare services that we're providing and the procedures are actually making a difference in patients' health status and their quality of life. They provide insight on the effectiveness of care from the patient's perspective, which is not usually what we're basing our decisions on, and complement the existing information that we have on the quality of care from the clinician perspective. They can be used to inform clinical practices, to develop and improve healthcare programming, planning, policies, performance measurement, and comparative effects analysis. Now, why is it important to really look at it from the patient's point of view? Well, the first thing when you're developing a PROM, or a patient-reported outcome measure, is you have to really drill down and understand what is the patient segment that you're looking at. So the way our current systems are built is really according to a disease type. So like, a cancer center or a chronic condition. But actually, in order to develop patient-reported outcomes that make sense, you have to understand what is the patient segment. And that is another jargon term, if you like. And what a patient segment is a population with shared needs. So within even, let's say, breast cancer, not all breast cancer patients have the same needs. So for example, younger breast cancer patients have oncofertility needs and financial needs, for example, because they haven't started their career yet, or they don't have savings, compared to a retired woman with breast cancer who has other needs that are common to other people in her position, or a metastatic prostate cancer patient has different needs than an early diagnosed prostate cancer patient. So that's what we mean by patient segment. And so it's important to really understand that the patient-reported outcomes measures are going to vary depending on the patient segment. So in order to really deliver on what matters to patients, you have to understand what shared needs they have and look at them at that level. And then finally, and this is something that came out of our working group, is who decides what matters most to patients. Like I mentioned at the beginning, traditionally, doctors decided what matters most to patients. And then at the policy level, governments decided, what to prioritize. But I would posit that it's actually, there's a great opportunity for patient advocacy groups to actually contribute to the conversation and rally together and get patients together in order to voice what matters most to them, and then to bring that to the higher advocacy levels. So in our PROMS working group, we were about 10 people, and we met 3 times because of COVID, it was a little less productive than we would have liked. We started working on some ICHOM's standard data sets from last year. So ICHOM, for those that are new to you, is the International Consortium of Health Outcomes Measurement. And they develop standard sets that include patient-reported outcomes, clinical outcomes, and other factors by patient segments. And so we looked at that. To get started, we looked at the lung cancer ICHOM standard set. And then the question that we asked ourselves in the working group was, should we limit ourselves to the existing standard sets, or should we start thinking about how we can contribute to new ones? Because ICHOM doesn't cover all disease types. And we did have several patient advocacy groups with us that were interested in developing this idea further. Like, as a patient group, how would we contribute to this conversation? And so we started out by looking at the lung cancer standard set, and we did identify some gaps, some commonalities between, for example, all of the cancer standard sets. But one thing that we did notice is that the PROM sets often neglected or underrepresented mental health and survivorship outcomes, and would also benefit from social determinants of health perspective. So we really started thinking more deeply about the role of patient advocacy groups in determining these PROM standard sets. We looked at a couple of patient segments. So we started with lung to kind of evaluate and compare, and that'll be in the next slide. And then we wanted to apply these insights to start thinking of, if we had to apply them to new patient groups or patient segments, how would we do that? And so our goal was really not to develop new measures. ICHOM does that, they do that very well. But our goal was really to start reflecting about, how do we as patient groups identify the outcomes that matter most to patients, and then determine if there's existing tools, validated tools that exist to measure those. And so we did review the ecology standard sets, and now we're really looking at what exists out there. So when we did review the oncology standard sets, we saw that there were a few commonalities. All of the standard sets included predominantly clinical and functional outcomes. That, like I mentioned before, that's always been measured in our healthcare system. Progression-free survival, very clinical, clinician-inputted outcomes were measured, because clinicians based their decisions based on that. But much less behavioral or quality of life measures. And because the clinicians were deciding what is important for them to make decisions, they weren't necessarily including, what matters in terms of quality of life for patients, because that varies greatly from patient segment to patient segment. And there was one, the group had actually thought that perhaps some of the behavioral measures and the quality of life measures, they were less present in patient segments where the prognosis was less positive. So the focus was really on survival and less so on quality of life. But that's something that we thought was really missing. Depression was an outcome identified in some of the cancer standard sets, for example, like breast and colorectal, but not for lung cancer. Same thing with sexual dysfunction. And so that's where we thought that perhaps some of these measures were indicative of less of a priority given to the quality of survivorship for cancer types, for example, in this case, that had less of a positive outlook or prognosis. So the emerging outcomes that we thought would be interesting, and specifically the lung cancer set, was things like respiratory rehabilitation, cardio-oncology, and in general, rehabilitation we thought was missing from most of the ICHOM standard sets. And it's a neglected outcome because it really improves the quality of life in terms of survivorship, but also even to prepare patients for surgery or treatment. It has been identified as providing better outcomes, and that seems to have been neglected so far. And finally, the social determinants of health should be included among case mix variables in the reference guide, since they affect access to treatment and diagnosis and therefore outcomes. So the main recommendations for improvement that we saw was really on the mental health aspect. Emotional and psychological well-being was really diluted into something that they called health-related quality of life. Otherwise, there was no direct measure. So we proposed a separate validated measure of psychological distress to be measured at the time of diagnosis, during treatment, and after treatment. For example, my work is mostly in oncology and in Quebec, and the Quebec Ministry of Health had actually published a guideline to measure psychological distress in all of its cancer centers. So something that was specific to psychological distress for patients is something that we believe would be a really useful outcome measure. And it should be an improvement in the priority. It should be a priority for the improvement of outcomes in the trajectory of care, and appropriate resources should be allocated. So what is the role of patient advocacy organizations? We already ensure that the patient voice is heard and valued, and that is one of our common focuses. We do this so that public policy in healthcare specifically can be improved, and we want to impact care delivery in a way that's meaningful for our patient segments. So in other words, we want to make sure that what matters most to patients, so in this case outcomes, is systematically measured and considered in the determining of trajectory of care. So in order to inform that, our working group was thinking about how to prepare a standard set. At first, we had to really clarify how realistic is it to collaborate with ICHOM right away or later on. And so what we determined is that the patient advocates can really contribute to the conversation, because as patient advocacy organizations or community organizations, we're closer to patients. And so we can actually get them to speak on behalf of themselves and then bring that voice to our advocacy work at the higher levels with government. So I just want to be clear that last year, Stacy Myers had presented how ICHOM developed its standard sets and their development process and their considerations when developing the PROMS tools. So we're not talking about replacing that. The validation of tools is a complex and rigorous scientific process. And so we're not suggesting to replace that. However, we do believe that patient advocacy organizations have a role to play to really identify the outcomes that matter most to their patient segments that they know the best. And then to even, contribute to some recommendations about the measures that are used. So how to do that? Well, the first thing is to do a literature review and see what exists for the patient segment or the population that your group is interested in. So you do an environmental scan in terms of, what exists locally, nationally, internationally. And then one essential thing, and one thing that's used by Porter and Teisberg and in VVHC Europe, for example, even by ICHOM, is to do qualitative research with patient segments. So this can take the form of surveys are kind of limiting. What is usually done and what's done at UT Austin, where Elizabeth Theisberg teaches, is to do experience group methodologies or focus groups, where you can actually speak to patients and get them to speak about their experience, their lived experience, not just in the healthcare system, but as a person in their own environment. So what is important to them? What are the values, and what are, indirectly without asking, just by having them speak about their lives and living with the disease, you can identify gaps in care and their unmet needs. And so based on that, you can put together, what outcomes need to be measured. Are they already measured? And if not, how to look for that. So that's where we identify the unmet needs, the gaps in care, and the services. And then ideally, co-designing the standard sets with patients. So this is the part that's traditionally been missing. I know that ICHOM does include patients at some phases of their evaluation. But importantly, as patient groups, we really have a responsibility to put our money where our mouth is and really include patients throughout the process of evaluating, what matters most to them. And so in co-designing the standard sets with them, the proposed standard sets, you can work with your medical advisors. So, most patient associations have medical advisory or scientific advisory committees. So to determine if existing validated tools exist for the outcomes that you've identified as being particularly important to your patient group. And then working, if there isn't any, if there aren't any that exist, validated tools to measure the outcomes that matter most to your patient group, then you can always work with researchers to potentially develop tools that don't already exist. So what can you do in terms of when we got started? We thought, okay, what's the point of doing this? Why should we even try? And what we realized is, well, okay, at first we thought about reaching out to ICHOM and collaborating on international standard sets. So the good news is you can do that already. You can, if you have an idea for a standard set that isn't developed. ICHOM just released a new list of new diseases or patient segments that they're going to be working on in the next year. So if the one that interests you is on that list, you can reach out to them and actually participate. If not, you can actually propose to lead an initiative. And so you can also, based on the work that you've done, the environmental scan, the work talking to your patient segment, you can publish your results, you can disseminate them, you can already talk to your government or health systems about, what's really missing in terms of systematically measuring outcomes that matter to your patients, and then proposing care delivery improvements based on your findings. So you can do that. You can work towards that as you collect more and more information. But right now, what can you do? Well, you can do this as of today, as of tomorrow, if you're not already doing it. And I know many of you are, but maybe in a more informal fashion. So you can speak to your population and understand what matters most to them in their own terms. And then based on that, lobby for greater involvement and participation of patient partners at strategic committees that actually have an influence with impact on healthcare delivery. So we talked in the previous conferences, we heard that if you're not counted, you don't count. And we also know that you can't improve what you don't measure. So in closing, I would invite patient groups to really think about carefully and consult their patients and see, okay, how do we make sure that the outcomes that matter most to our patients are not just measured, but acted upon and form the basis of public policy decisions going forward. So I hope we caught up some time.
Thank you so much, Eva. I really appreciate that wonderful presentation. So much to think about. And I am going to move us right along to our next presentation. I'm very pleased and honored to introduce Shanil Pathak, the co-founder and CEO of Zoe Insights, also lived experience as a caregiver and as a caregiver advocate. Shanil has been the chairperson or the co-chair of our data working group for the past year, since last year's 2019 summit, and I'm excited for his report back to all of you. Welcome, Shanil. Please unmute, Shanil. We can see you. There we go.
Hi. How's it now?
Perfect.
So I'm just going to share my screen.
Yep, great, thanks.
Hey, can everybody see my slides?
Looking good.
Okay, thank you, Leah, and also the organizers for the opportunity to present. As Leah mentioned, we are the data working group, and what I'll talk a little bit about is our history, what we accomplished, and our call to action. So we were formed at the last for the 2019 summit, this summit on redefining the future of healthcare. And the goals of, at the time, what we found the gap in is about understanding what it means for patients to own and access their data. In addition is there's several, people are becoming data aware, and people are understanding how important health data is in the decisions about your health. The challenge is to acquire that data. And also with the system being so fragmented, there's many stakeholders who are vying for your data. And so what rights do you have and what obligations do they have in terms of your data? So that was the focus. And then, excuse me, and then our goal of a committee is to come up with a declaration of individual health data rights and obligations in Canada. And so this is quite broad and quite general, but we wanted to put it out there, and then the goal is to socialize this declaration and get buy-in for the community. A bit about who's on the working committee. I mean, there's myself. We have Jennifer Graham from the Canadian Congenital Heart Alliance, Louise Binder, as you know, Eric Sutherland from Kai participated until he had to be he had abstained for other work, but we appreciate his contribution. And we also have Leah, and Leah's done. I want to put a shout out is that a lot of the heavy lifting and a lot of the writing was done from her. So I do appreciate all the work that she's done. And so when we started the group in January of this year, we met monthly, and we had a process that accumulated to a draft copy. So the first thing we did was we investigated the current landscape. We looked at the Supreme Court ruling, the laws and regulations, like obviously PIPEDA, and also the provincial laws and privacy. We looked at there's an Ontario Privacy Commission ruling on access. And then we went abroad, especially to Europe, to understand GDPR and what rights that they've implemented in their rulings and the laws. Then we also looked at the Naylor Health Innovation Report and their findings related to health data. We also have the Pan Beacon Report. And once we collected this information, we started drafting the declaration. And then we expanded this out to get consults with health lawyers as well as privacy experts. In about September, we had the draft ready where we socialized it with a closed set of stakeholders to get their feedback. We digested the feedback, and now we're ready to socialize it to this audience here. And our goal in the coming months is to, one, receive feedback from the draft declaration. We would like to seek endorsement from this audience at the summit. And then we want to publish the declaration to custodians. I'm sure there's going to be a bit of a conversation with many custodians, but at least we want to have a position of where we feel we stand as patients, caregivers, as well as patient organizations. The draft declaration is quite detailed, and so there's 11 sections. And I think I would summarize it in this way. We want to create awareness and control, awareness that you have the right to your data, and also that you have control of your data, which is in other people's hands. You also have access and access and acquiring your data in a usable format. So that's very important. Often as a caregiver, and many of you know, is that we carry around binders of paper, which is very low utility. In Europe, you have the right to acquire your data in a machine readable format because it increases the utility and portability. You also have the right to restrict on how it's used, who it's using it. And so these are some things we touched upon, but we also looked at the obligation to share the data. So we looked at a balance to make sure that we don't impede progress in either policy or research. And for example, we had a debate on retroactive rescinding of consent. And technically that's very complicated. And so we look at, from this point forward in terms of your obligation to share and your rights. So what we'd like to do next is everybody should have a copy of the declaration, but if you don't, please contact Leah or myself. And we want to socialize this, receive feedback, and then we'll incorporate that, have a dialogue. It'll be an iterative process. And then we're looking at in the new year to publish the endorsed declaration. Or I should say we want to publish the declaration and receive endorsement. And that's my short presentation. So we didn't go into the details of the declaration just because it is quite lengthy, but here to answer any questions.
Thank you so much, Shanil. Everything was sent out as a pre-read, the declaration as well as the executive summary included with hot links to them. If anyone for some reason missed that email or went into their junk mail, don't hesitate to reach out to Shanil or myself, and we'll be sure to get that out to you. It is quite detailed, and so it would have been a lot of to convey it all to you here. So hopefully you've had a chance to look at it. If you haven't, please do take a look at it ASAP. And so I would like to invite Eva, Shanil, Scott, Jennifer, Margaret, all of you to unmute and bring up your video. And we have a bit of time for some questions and answers. So some of them are a little bit more directed. Some of them are more wide open. We have a couple that came in through our Q&A box. If anyone hasn't shared their question yet, please do so now. And I do have a couple of others if we don't have a lot more that come in. The first one on the list here is specific to CHCs and virtual care. So Scott, how did, to your awareness, I know there's many of them across the country, but do you know of any examples of CHCs that were able to overcome, digital equity barriers? Certainly we've heard about some of them in our past presentations, for their clients, and whether that's because they don't have devices, they don't have Wi-Fi, they don't have electricity, they don't have the understanding of how to use the device because maybe for a variety of reasons, it could be linguistic or age, etc. So are you aware of some innovations or approaches that some CHCs might have taken in helping overcome some of the digital equity barriers that their clients might be facing?
It's a great question, and I'll say stay tuned. We're hopefully over the coming months going to be undertaking a national environmental scan. We're just waiting on approval of a small pot of funding to do just that, to document experiences with virtual care and focus specifically on virtual care in the context of vulnerable communities and local and client barriers to care. So I hope to have some fantastic innovations and experiences to share. What we've heard to date is more on the side of the actual barriers experienced by community health centers. You know, that they don't have the infrastructure, they don't have the equipment to support, you know, virtual care, virtual care delivery at the level they would have liked to. That there are community regional barriers like lack of access to broadband internet, client barriers in terms of their access to equipment and so forth. So I do know that a lot of community health centers have been doing virtual care. We haven't quite been able to pull back the curtain really on what the success
Measure how, yeah.
how and
Yeah.
talk about the innovations, but it's absolutely a priority of ours. So hopefully at some point in the new year we'll be able to share those.
Great, so important.
I wish I
And,
had something more to
that's
share.
okay. We know that it's not a panacea for all. You know, I've heard, you know, in talking with a CHC and working with a board, for example, of a CHC in Ontario, of you know, having to look for, you know, donated equipment, right? For example, to fill gaps, or getting donations from corporate sectors such as TELUS or others to be able to do that kind of work, or having to look for, you know, and encourage and advocate with the city to have Wi-Fi in parks and other public spaces outside of cafes and that sort of thing. So I've heard a little bit just in my interactions as a consultant with couple CHCs, but yeah, we know that digital equity and digital inclusion, you know, that there are many barriers, especially for people who have, you know, struggles with the determinants of health, and that it's not the panacea for all, and we really need to do better. I think last session we heard that in First Nations community, the commitment in the mandate letter is to have connectivity for all of them by 2030. You know, that just doesn't cut it. So thank you very much for that.
Yeah,
and we look forward to hearing more, and we'll share it. We're happy to share when you do.
Well, and just to add on that also, that it's critical that we be mindful of this, and we make sure that this not get lost in the mix, just as you know, a lot of the mechanisms and ways that we do remote work and the business world and the world of retail and so forth have been accelerated in terms of moving to the digital platforms. You know, we're fearful that there's going to be an acceleration in terms of government policy, funding, planning for virtual care, absent you know, thoughtful considerations for who that works for and who it doesn't.
Inclusion, yeah, equity and inclusion, and creating greater disparities accidentally along the way. Thank you. A question for you, Eva, around what are best practices and necessary resources for the use of validated proms, and any thoughts on how the uptake of proms can be spread more broadly?
Yes, sure. That's a great question. I also just wanted to mention, I neglected to mention that I clearly was working in a group with many other people, and I didn't mention them, but we did have Kathy Bernard, Antonella Scali, John Sodden, Alamir, Christina Sitt. And so we did have, you know, we wanted to work on 2 new patient segments, so melanoma and psoriasis. And so we really thought a lot about this, like what are the best practices, and there's other international initiatives. So besides ITROM, there's also PROMIS, PROMIS, which is an initiative in the United States that actually works on proms. They have a really great website that you can go and consult to see, you know, what validated outcomes measures exist currently, and they share a lot of their tools. Same thing with ITROM if they exist. So that's one good best practice. The other thing is really depending on your size in terms of, you know, what resources you need and everything, you really have to check, you know, the importance of fundraising. Like, as we know, as a nonprofit, you know, what is your capacity? You might not have a person to dedicate to this. So just start small. Like, you know, figure out a couple of outcomes that are really important for your patients that are perhaps not already included. So I think the first step is really to do that environmental scan, just to talk to your scientific advisors or the doctors that you work with and see, okay, what are you currently measuring and how does that line up with what our patients are telling us? Like what's missing? And then maybe pick those things and say, okay, how is that being measured currently? If it's not, then go and look elsewhere in some of those you know, resources that I mentioned, either ICHOM or PROMIS. There's the SPORE initiatives as well in Canada. So anything that, you know, is really looking at, you know, how to involve patients more, but really looking at what is the outcome that we want to measure, and if there's a tool, and if not, then work with clinicians and researchers to see, you know, what is a very simple way that we can measure if this outcome is actually being attained or not, right? Because in value-based healthcare, what we want is to see a significant improvement in outcomes for the cost of care over the whole trajectory of the life cycle of the disease. And so, and of the life cycle of the person. So not just like in that one intervention, but along the whole life cycle. And so I think that doing it really with patients, but also clinicians, but always with working backwards with the outcomes in mind. So what does the patient want to attain, and then working backwards with them to see how would that affect the trajectory of care. And there are some good, you know, validated tools that exist. And if they don't, then start thinking about how you can collaborate to create them.
Awesome. Thank you so much, Eva. We are running late and we're going to be shortening our break and our much needed mindfulness meditation as a result, but I don't want to shorten it too much more. There is a question specific to data. Shanil, I think, spoke a bit to it already, but if you want to add anything, Shanil, and go for it. You know, there is little clarity on who owns personal health data. There's a lot of confusion in the system on it. So I think, you know, it's being acknowledged how important it is that the draft declaration clarifies this fundamental point that individuals own their own health data. You know, thoughts on how we can help spread this information, this fundamental point, you know, and then what are the rights that flow out from that data ownership to all relevant stakeholders, including the general public, patients, and data custodians. I know that's some of your call to action around the endorsements, and this can also be some really good breakout conversation and generating ideas around this. But do you have any thoughts that you would like to share on this one at this point, Shanil?
Yeah, I mean, there's awareness of your rights to the data. And what I think the challenge is, there's one thing about rights, and then there's another thing about habits. So if you actually go abroad outside of North America and Europe, it's customary that everybody gets a copy of their medical file and they keep it with them. It's like, I've talked to people in South America, Africa, Asia, and that culture is not there in North America because we just assume the doctors have it. And sometimes it's misleading when we have custodians advocate that we have patient portals, gives you access to your data when it's incomplete. So that's one thing, which is about awareness. The second thing is about a habit. And then third, and I will say that this is a conflict of interest to me saying this because we have a digital app, that's my startup, but where do you put it? There's one thing about getting your rights, but where do you put it, right? And this is the challenge, is that we often get our data in paper form, which is not portable and cumbersome. So I think those are the three things that we need to tackle in next year.
Thank you so much to all of you. This has been an incredible start to the day. I am very honored to introduce Rina Ruparelia. I apologize if I mispronounced your last name, Rina, who's going to lead us through an abridged mindfulness meditation session. We will be returning for our next session, multi-stakeholder moderated panel, opportunities for the growth of value-based healthcare across Canada at, I think at this point it's going to be at 1:40. So let's take 5-6 minute break with some mindfulness meditation, and we'll all reconvene for the panel at 1:40. Thanks, everybody. Over to you, Rina.
Thank you so much. I actually think this presents an interesting challenge. What do you do when you only have a minute, right? How can we bring a mindful moment into our day when we have a minute? So it definitely works. But I also shared in the chat that I do a free session every Wednesday at 2 p.m. So if you need something longer, feel free to join or refer anyone who may need it. So welcome, my name is Rena Ruparelia. I sit on the board for the Canadian Association of Psoriasis Patients. I'm also someone who lives with psoriasis, and I teach mindful living practices to individuals and professionals. So let's take a minute just to settle in. I invite you to let go of everything we've talked about, what you need to do after this. Just give yourself the gift of being here for the next few minutes. We're going to focus on our breath today. This is going to help refresh the body and the mind so you can move forward feeling good and clear, and also arrive into your body and into the moment. So just remind yourself that, meet yourself where you are today. And let's begin by finding a comfortable position. So one that's awake and dignified. If it's accessible to you, perhaps having your back straight but not stiff. Planting your feet equally on the ground, maybe pressing them down for a moment. And then allow the eyes to close, and if you prefer, just focusing on a spot on the ground in front of you. Now let's just take a minute to roll our shoulders slowly forward and down and forward and down. And now let's roll them back. So rolling them up, down, and back just a couple of times. Remembering to breathe, and now perhaps leaning the head from side to side. So allowing the left ear to move towards the left shoulder. Again, if that's accessible for you, and the right ear to the right shoulder. And then settling somewhere again in between. Maybe rolling out the wrists or shaking them. And then allow your hands to rest on your lap. And just do a quick scan of your body. Is there anywhere that you're holding, maybe in your stomach, in your back or chest, perhaps on the eyes or the jaw? And I invite you to soften that area a little. And when you're ready, let's come into our breath. We don't have to change it in any way. Just notice how the breath comes into the body and out. Making no effort to change the breath or the breathing. Just noticing how the body breathes itself without thought, without effort. How your body knows how much air it needs. So let's just take the next 30 seconds to sit quietly and notice your breath flowing gently in and out of your body. Perhaps noticing the stages of a complete breath, from the in-breath to the pause that follows, and then the exhale and the pause that happens before taking your next breath. Maybe even feeling the chest rise and fall as you breathe. And before we close, let's just take a moment to appreciate your body, your breath, perhaps saying thank you. Taking a moment to appreciate yourself. Having this moment to pause and be mindful is rare in our busy lives. So knowing by just taking this minute, you're contributing to your overall health and well-being. And before opening the eyes, I invite you to empty the air out of your lungs. And let's take a deep inhale through the nose or the mouth. And let's do a loud sigh out the mouth, letting it all go. And when you're ready, perhaps moving back and forth in your chair gently and wiggling fingers and toes, giving the head a shake, maybe taking one more deep breath. Enjoy the rest of the conference. Thank you for having me, and I hope to see you all soon. Thank you so much, Leah.
That was beautiful, Rena. Thank you. Just even doing the final breath and
so nice, right? Just to let go. Thank you again. All the best. Thank you for all the work you do.
Appreciate that. Wonderful, Rena. Thank you. I am very honored and pleased to introduce Monica Slovanik DeAngelo, who is the Health Director at Conference Board of Canada and running their initiative called Value-Based Healthcare Canada. She will be moderating our next panel. And I am also very pleased to, well, Monica could do the rest of the introductions. So over to you, Monica.
Thank you very much, Leah. And thank you to Rena. I never take the opportunity to take a few deep breaths throughout the day. So this is great. I feel refreshed. So welcome to everybody to the panel on opportunities for growth of value-based healthcare across Canada. This panel session is intended to draw on the earlier conversations and presentations we heard today to explore the opportunities for value-based models and for value-based initiatives across Canada. As we all heard, the implementation of value-based models of care hinge on data, patient data, care outcomes data, and cost data. However, the context within which the data come from and within which they exist needs to also be considered. And specifically, factors that are outside of the health system that influence health need to be addressed. Relatedly, silos need to be dismantled within healthcare, and we talk about this a lot, but also between sectors and between ministries. This also speaks to a shift from sick care to healthcare, and importantly, the need to recognize the influence of social determinants of health in value-based solutions. As on the first day of the summit, Kwame Mackenzie emphasized in very, very practical terms, the fact that innovations will increase disparities if we don't design them not to at the outset, at the very beginning. So the importance of co-design in engineering solutions for improving outcomes for all population segments, including those who face barriers, or maybe mainly those who face barriers due to poor determinants of health, cannot be understated. Digital equity, for example, is now a component of health equity, and this needs to be considered when assessing the value of innovations in healthcare as well. To this end, advancement of value-based healthcare needs to be co-driven by patients and by caregivers with diverse and relevant lived experiences. Our panelists, who I will introduce momentarily, will provide insights into opportunities for advancing value-based approaches to care with a view on data sharing, measurement of patient-reported outcome measures, equitable access to innovations, and integrated models of care. These are all concepts that we just heard about earlier today. Based on their expertise and wealth of experience, they will speak to some of the strategic opportunities in Canada for growth of these value-based initiatives, as well as the role of social determinants of health in the implementation of value-based health solutions. So with that, it is my pleasure to introduce our panelists. I will start with Christine Neglia, who is the manager of Ocap and Information Governance at the First Nations Information Governance Center. Then we have Maria Santos, who is First Nations Data Center Manager at the First Nations Information Governance Center. Then it's my pleasure to introduce Paul Larchevêque, who is the Innovation Director at the Quebec Ministry of Health and Social Services. Paul, I said that in English as opposed to using my accented French. and finally, we're delighted to have Rodney Burns, who is the Chief Information Officer at the Alliance for Healthier Communities with us. And so I welcome you all, and maybe if Christine, if you would like to start by addressing, both, and then we'll take turns. We have about 25 minutes or so to address the questions of strategic opportunities for growth of value-based healthcare initiatives, as well as the role of social determinants of health. So maybe if we start with you, Christine, then we can move to Maria, Paul, and Rodney, and then depending on how much time we have remaining, we can have an open conversation as well. And it is intended to be an interactive session, so by all means, don't feel too confined by the time. Christine, you might be on mute. There you are.
All right, I've passed the first test. Thank you. Good afternoon, everybody. My name is Christine Neglia. I am a member of the Curve Lake First Nation in Ontario, born and raised in Toronto. I'm speaking to you today from Ottawa, from the unceded territory of the Algonquin people. And when I do my land acknowledgement, in my acknowledgement, I'm also acknowledging not just the land, but I'm acknowledging the laws, the languages, the values and customs and songs and ceremonies of the Algonquin people that still exists to this day. Today, I'm going to talk a little bit about the principles of Ocap, and why I'm here is in the Declaration of Personal Health Data Rights and Obligation in Canada, Ocap is mentioned. And I wanted to talk a little bit about the principles so that everybody has a clear understanding of what they are and how they can be, how they could support the declaration. So first I'll talk briefly about what the principles are. The First Nation Principles of Ocap establish how First Nations data and information will be collected, how it will be protected and shared. When I talk about the First Nations principles of data, it's really important that I'm specifically talking about First Nations. I'm not talking about Inuit, and I'm not talking about the Métis. Each of these groups have their own articulation of how data should be collected and used. And this articulation is in line with their worldview and with their customs and values that are different from First Nations. So when I talk about Ocap, I'm talking about a very specific First Nations principle. Standing for ownership, control, access, and possession, Ocap is a tool that can be used by First Nations as they move down the path towards First Nations data sovereignty. It's a strong information governance tool that really looks at how information should be collected, gathered, used, disseminated, destroyed if need be. And it's in line again with the First Nation protocols. The first principle is ownership. Ownership refers to the relationship that a First Nation has to its First Nations data. And this is different. Just as individuals have a relationship of ownership over their personal data, First Nations are asserting ownership over collective data. So when I say, when I talk about First Nations data, it's data that is about First Nations, right? Health, housing, child welfare, education. It's also it's data that's about our lands. So our lands, our waters, our resources. And it's also data that comes from us. And that's our language and our songs and our ceremonies. So the definition of First Nations data is pretty big. And it's holistic, and it reflects our understanding of data. So ownership refers to First Nations at a community level have a collective ownership of their data. Where we run into problems is that community level data is not recognized by major federal legislation. It's not recognized by the Privacy Act. It's not recognized by the Access to Information Act, and it's not recognized by the Library and Archives Act of Canada. And where this is problematic is that it specifically exposes both First Nations data to vulnerabilities such as ATIP, but it also way down the line, like after a certain number of years, it could also expose individual First Nations people with their identifiers in ways that no other Canadian is exposed. So looking to get recognition of ownership at a community level is one of the assertions of First Nations. Another, the Ocap also asserts that the intentions and inherent rights of First Nations to regain and maintain control over all aspects of their lives. So that includes people, it includes lands, institutions. This inherent right and this maintaining and regaining control also extends to our data and to our information, because our data and our information is a resource. Control, the principle of control affirms that First Nations, their communities, their representative bodies are within their rights to seek control over all aspects of research, of data, of information management that impacts them. The principle of control asserts that First Nations people, the representative bodies must control this. They must have more than just a stakeholder role in how these pieces or processes are rolled out. When we look at the principle of access, this is a two-pronged principle. This principle first asserts that First Nations must have access to information and data about themselves. They must have access, of where data is held. Of where data is held, regardless, whether it's at universities, whether it's governments. And the other part of the access as well is that First Nations should also be able to control who else has access to their data. Not just who has access, but who else doesn't have access. And this is really important when we think about all the different types of institutions and organizations that access First Nations data without the benefit to nations themselves. The fourth principle is the principle of possession. I'm so sorry. It's not my phone, it's actually just my timer. So the fourth principle of possession is that literal principle. So to fully be able to assert ownership, control, and access, the best way to do it is to physically possess the data that you have. Possession is the literal mechanism, the actual mechanism that First Nations can use to assert the four principles. We know that there's not a lot of funding for nations to be able to build data servers and networks in their First Nations. So the alternative to, a viable alternative to possession is stewardship. So building those relationships with a third party who they will act as stewards and manage the data, but the ownership, the control, and the access all still remains with the First Nations themselves. How much time do I have left?
So everything you're saying is so ever important, but if you don't mind, we'll move on to the next presenter just so that everybody has an opportunity to present, if that's okay. Unless you have you'd like to conclude with. Yes.
When we talk about the principles of OCAP, one of the key pieces is about organizations making space for OCAP and making space for First Nations to articulate what OCAP looks for them. And I think there's a really important opportunity within the declaration to be able to hear that voice and to find out what that is. Miigwech.
Thank you very much. And we appreciate you setting your alarm to do that. Maria, would you like to follow up on that, please?
Hello. My name is Maria Santos, and I am the First Nations Data Center Manager at FNIGC. And Christine did a great job describing OCAP and First Nations data sovereignty. And so I'm going to take a little bit of a different approach and talk more about the social determinants of health and relate that to integrated models of care and the patient-reported outcomes measures. And so as some of you may be aware that Indigenous people, they tend to view health in a balanced and holistic way with the connections to spiritual, emotional, mental, and physical dimensions. And so, the models of care need to reflect that. And it's not surprising that within Scott's presentation that you can see examples of integrated models of care from the community health centers that are within Indigenous settings. One of the things that First Nations encounter, there is a fragmented system. And so you don't necessarily just also have to deal with the sectoral silos, but First Nations have to encounter the jurisdictional barriers in terms of getting the services they need when they need it. And whether it's being funded by the provincial authority, health authority, or the federal health authority. And so we have tools such, principles such as the Jordan's principle, which was created to address some of these barriers for First Nations children. But even with regards to data, with regards to COVID data, trying to look at that national picture of what does COVID look like amongst First Nations, the data is housed in so many different places that we cannot get a full sense of what the impacts of COVID has been for First Nations. So with regards to, I guess, opportunities, I've seen examples where organizations have taken a holistic perspective. So it's not just the comprehensiveness of the services that are provided, such as primary care and the supportive services as well, but it should incorporate this holistic perspective from the bottom up. So it being within their policies, within the mandate, the vision, the goal of the organization, in the leadership, in the staff. You need to develop those right partnerships and the relationships. So, and with patients being at the center, so that you can make sure that clients are empowered to be able to be engaged. So when talking about the social, I'm kind of jumping around because I kind of just separated it between the two components there. So with the social determinants of health, the thing to realize, you know, with the determinants of Indigenous health, we've talked about, there's talk about the proximal, the intermediate, and the structural determinants of health. And one of the ones that tends to get neglected is the structural determinants of health. And those are the historical, the political, the ideological, and economic and social foundations. So those need to be considered. And in order to make, to be able to address the health inequalities, we need to change those underlying structural determinants, and rather than just addressing the symptomatic effects. So when doing that, one of the examples I see in relationship to data is in order to be collecting information with First Nations identifiers, it's difficult. You see you have a conundrum here where, because of the structural racism that exists, First Nations may not necessarily want to self-identify. So so this is why I'm saying, until you can address those structural determinants, then you're probably going to be able to get better data. And what was one of the other, the other thing that I wanted to mention was to also include a strength-based perspective. So a lot of the times with regards to patient reporting outcomes, we want to be able to measure those inequalities, but we also have to be careful that we're not creating more creating those stereotypes. So we also need to consider strength-based indicators. And those can be anything like Christine had mentioned, the connection to land, relationships, and communities. And so it comes back to, again, that it's a very holistic perspective when developing these indicators. And I think that's pretty much all I wanted to touch upon. It wasn't very weaved in too well, but listening to the presentations today, they were excellent presentations, and I was just trying to point out some of the things that highlight some of the things that were mentioned.
No, that was excellent. Thank you, Andrea. That was very well presented, and it does absolutely tie into the previous discussion. So thank you very much. And Paul, I will turn it over to you, please.
Good afternoon, everyone. My name is Paul Larchevêque. I'm the Head of Innovation at the Ministry of Health of the Quebec government. I'll be commenting maybe with a bit of a different angle, and I'll be arriving at the issue from from the huge challenges we are faced with in our healthcare system and delivering value to patients, and all patients that is, which is becoming and will continue to be a tremendous challenge. The issue won't go away, and we need to start addressing that. The reason I'm starting there is because the Innovation Office was created in Quebec with this in mind, of saying we need to integrate more innovation. When we're talking about innovation, we're talking about social innovation, organizational innovation, and also technological innovation. So we've got this perspective which reunite all the three of those type of innovation. And when we were faced with the challenge of saying, how do we go about accelerating the introduction of innovation and the adoption of innovation? The only way forward was, how do we create value through the introduction of innovation? If we're not able to introduce value and demonstrate value, it's going to be very hard to challenge people out of their current position, to create the learning system we need to create, and to get all the people and all the patients involved. So we went with this basis, and with this basis in mind, we've started to use the integrated care concept, and that you've been referring to all along this afternoon. And this integrated care concept, initially was integrated episodes of cares, and slowly is becoming integrated health for patients, or for the population, I should say. So that's where the social determinants of health are coming in, because if you really want to act on the ultimate outcome of creating a better care for the population, you need to work on the social determinants. Your integrated perspective is not what's happening at the hospital, what's happening with the patient, it's what's happening with your life and your life habits and whatnot. So we have been using this as the basis for which we would be looking at the value of project and trying to demonstrate the value of innovation that were proposed to us. The other thing we did is we said, it's fine to look at an innovation at its face value, but we need also to understand what it does in terms of providing a solution for the problems we've got. And so the way we've developed this kind of equation that we're using, we're having a lot of fun with it. And this equation is saying is that to determine the value of innovation, the first thing you need to take in consideration is the value that it delivers to the patient. And this value needs to be defined by the patients and with the patients, and make sure that we are integrating this perspective and understanding that. We've got tremendous initiatives in Quebec with the partner-patient concept. And I don't know how it translates directly, but it's patients getting involved, very much involved in their management of their own disease. We've got projects on the go, and Eva that was speaking earlier is involved with the proms and how to implement projects that will help us become better and put that to practice and make sure we're using that. So all this patient aspect is the first part of this equation. But the other thing we're asking projects to talk to us about is, if we were to introduce your innovation, if we were to take in consideration what you're proposing to us, would it help us with our access problems? We've got access issues at first line access to physician and nurses. We've got access at emergency. We've got access issue at surgery, and so on and so forth. So how can you explain to me how this innovation is going to help us with this access issue? How it will help us with the problem we've got with not enough human resources being able to deliver all the healthcare we want to deliver. And finally, how is it going to help us solve the cost and efficiencies issue? So we're putting the bar a little bit higher with innovation, but at the same time, the argument behind that is saying, if we're able to build this value, if we're able to demonstrate this value, it becomes very, very tough to resist to it. It almost, you cannot argue against it. You've got a patient which is having access to better treatment as defined by himself. We've got the access issues, we've got the human resources issue, and we've got the cost and efficiency issue. So in a nutshell, this is what we're trying to do to help create a value system which is based on value by trying to measure. And to do those measures, one of the things we need, and I'm sure Rod will be speaking much more about that, is we need, what's data? Is that what we need? Yes, we need lots of data. I'll finish here. Thank you.
Thank you very much, Paul. And over to you, Rodney.
Good afternoon, everyone. I'm Rodney Burns, the Chief Information Officer at the Alliance for Healthier Communities. It's an association of 110 community health centers, Aboriginal health access centers, nurse practitioner-led clinics, and some community-governed family health teams. And so we're an association, and I provide support and leadership around data and technology and systems to help capture the evidence to inform decision-making to improve outcomes at the end of the day. So for me, I am a Irish-Scottish descendant. I live just north of Lake Simcoe, and this land that I live on is enjoyed and has been historical lands of the Chippewas and the Rama First Nation here just east of the city of Orillia. And I really do appreciate being able to speak to you today. I think the presentations have been fantastic. For me, as you can see, I'm a little bit gray. I've been learning a lot about history and the frailty of my own life as I age. And as a father, my greatest gift is as a parent is to really impart independence to my children. And that means they're educated, that they are aware what they can and can't do. So I have 3 young adult children, and I'm very proud that they are starting their lives off on the right foot. That said, I think as we look at healthcare and value-based healthcare methodologies, a lot of these pieces, I'll call them facets of a diamond. They need to come together to create the brilliance, and we've got to keep our eye on that ball. My partner is a teacher. So to Paul's point, this is not just about healthcare. How do we think about the journey of a person through all facets of their life, from the day they're born to the day they die and thereafter, to inform health and well-being of those that move forward? We need to have responsible use and data that will allow thought leaders, policymakers, providers, and the individual to be informed about what that means. What is the sense making in all of that data that's becoming available digitally as we go forward? It's not going to become any less. But many of our member organizations have been telling us at the Alliance that there's a huge need to be thinking holistically about an individual. So many of our organizations will do harm reduction approaches to services. This is not about cure, right? One size does not fit all. So how do you measure where you're reducing the burden of illness on an individual, but maybe not really healing them per se? If that's what that individual wants in their life, we need to learn how to respect that. The business side needs to find ways to measure that and incent that at the end of the day. So for me, this is about a massive transformational power shift. We give away the power, which means we help to educate those that we're serving and using information in a way that they can understand. It doesn't have to be, you don't need a PhD in epidemiology to figure this stuff out. The technology's there to say red, green, or yellow. You're on the right path. You're headed towards the goals that you've identified. That is powerful. And if we can help individuals think about their own life journey, wherever they're at in it, and think about how to move forward in a way that fits with their circumstances, that's the power of what we're trying to do when I think about value-based healthcare. So all of my comments means we're taking a holistic view of the determinants of health here, right? It's not about, our practice is about slicing things down to the most homogeneous micro element, but putting them all back together into a single story, a single piece, much harder to do, right? At the end of the day, but that's where we've got to think collectively about how do we get there to actually say to an individual, we can see progress, you're on the right track. And that voice is critical to say, I want to go in that direction. It's not about, and when I started my career 30 years ago, I used to read charts and do chart audits, and I'd see patient is non-compliant, meaning my clinical advice was not followed, and therefore this person deserves the morbidity that they're suffering with. That has totally been turned around, but it's the insights and having your eyes open to say, this is where this client wants to be right now. How do we reach out to where they're at? So to that regard, we've heard some questions about digital equity. A lot of my time is about removing barriers to digital participation. We're going to be moving forward. So how do I think about my children being able to participate at, in a digital society that is just? So a lot of what we do is about social justice, health equity, including digitally accessible services for everyone that lives, at least in the province of Ontario. Even today, I was on a national discussion looking at how do we uniquely identify everybody digitally? That's just the starting point of this story, let alone how you control, as Christine said with the Ocap principles, how do we think about access, control, and possession of that information by whom, and how is it done in a way that government and the big agencies and private sector are transparent with how they're using that information? Is it in my best interest to share my information? So I think this is not an end state by any means. We've got a lot of work to do, but there's some really great work going on internationally in this regard. And I think Canada's started down the right path, looking at how do we actually move some of these narratives forward and on the ground make it happen. So when COVID hit, we were fortunate to be able to go to TELUS Health, and they gave us 600 smartphones and prepaid SIM cards that were issued to our clients who are members of the consumption treatment services. They have opioid addictions. They need daily service. But with COVID hitting, a lot of the organizations shut down. So these phones gave them an opportunity to call in, coordinate services, and continue getting their services in a safe way. At the end of the day, the most powerful story that came back to me was a 45-year-old gentleman, homeless, got one of these phones, and it was South Riverdale Community Health Center that had this experience. The first thing that individual did was call his mother that he hadn't talked to in 2 years. That is well-being. That is removing a barrier. That is health. So, we're just very pleased that even the United Way in the Greater Toronto area has provided the Alliance with a grant for additional $20,000 for more devices. So we're going to continue to try to close device and internet service access barriers. But the biggest challenge will be digital literacy. Do people know how to use these tools and the data that comes across them in a way that's meaningful for them? So that's the kind of comments I would have from the messaging that and the presentations we've seen today. I've been really impressed and always am motivated coming to this conference. So thank you for inviting me to share a few words.
Thank you very much, Rodney. That was excellent. Thank you to you all. Leah, I see you've come on. I'm not sure time-wise whether we have a chance to look at some of the questions or not so much.
I am anxious to have us go into breakouts. I know that it is unfortunate that we are cutting short. I'm so glad that we were able to hear the perspectives of all of you, Rodney, Paul, Maria, Christine. I'm scribbling notes furiously as you were speaking, and it's been really helpful how you've reflected back on what we've been hearing and expanded out from the work that you're doing on different pieces of it. And I think a lot of light bulbs certainly going off for myself. So I don't want people to lose the opportunity to now go into breakouts and have some deeper dive conversations with each other about all of this incredible, these ideas and this information that they've been listening to for the last 2 hours and 13 minutes at this point. So unfortunately, we do probably have to wrap the panel at this point. For those of you who are facilitators in breakouts, please get there as quickly as you can. Share with the participants that you're welcome to go past the 2:30 mark. If the group that you're with would like to talk longer, by all means, please stay in breakout for as long as you're able and as you see fit. And I just want to again convey my most sincere thanks to all of you. This has been a really inspiring and illuminating panel and series of presentations. So thank you, everybody. And for those of you who are not patients and caregivers and attending on Thursday, all of our other healthcare stakeholders who've been joining us, this is your last day with us. Thank you, all of you, for coming. I hope you're finding benefit from all of this information and sharing it within your organizations. Don't hesitate to reach out. A, fill out the evaluation. B, we will be sharing the working groups that come out. And while they're patient-led and caregiver-led, having other stakeholders that are passionate about these concepts and participating is extremely beneficial. We certainly found that with our data working group. So inviting you to take a look at what comes out as we're moving into our working groups next year as well. So thanks, everyone. Let's go break out.
Hello? Hello?
Hi, I'm just trying to get to a breakout room.
Myself as well. Yeah, I don't know how. I'm trying to do the same thing. I put a message on the chat,
Yeah, so did I.
but I don't.
I thought it was just me.
No. I text Leah, but haven't got a response yet. So
There are a few people having problems getting on when you read chat.
oh, is it? Okay. Maybe I'll just call. I'll call Leah.
Okay.
1 second. I'm gonna put myself on mute.
Okay. I'm Matt. Are you there? You're on mute, Matt.
There we go.
Okay. I can't get into my breakout room.
What breakout room are you in?
1. And I think Chanel is also having problems there.
Okay, I'll send you the link for it.
Okay. And where do I get that link? Do I just have to downsize the screen?
I just sent you the link, so you can just open up your email and click on it.
Okay.
It'll kick you out of this one.
Ah, okay. So I leave this and go into my emails, eh?
Yep, that's right.
Okay. Thank you.
No problem. Hi, Chanel.
Online now. Hi, Matt. All right. Thanks,
Okay.
Leah. Okay. Goodbye.
Bye.
Matt, how do you enter the breakout rooms?
What breakout room did you want to go to?
I can't see any of them. I don't know. Like all it says, all I see is that breakout rooms, check the lobby for your room assignment, but there's no message besides that. And so I called Leah saying the chat people are saying that they can't access some breakout rooms. So maybe you could just instruct me how to do it.
Yeah, I can send you a link. The reason is because the I mean, there's a separate email for
Well, that doesn't
for the breakout rooms, but I'll just send you a link to one and you can join it.
So who's communicating the links to the different breakout rooms?
It would have been Leah or Antonella.
Okay, so what I suggest doing is in the chat and broadcast a message to all panelists and attendees, the different breakout rooms.
Oh, so all of the attendees and that they view the entire meeting in a totally separate portal where the breakout rooms are on the side and they have a clickable link to join them.
This is confusing.
It's confusing because you're just in Zoom, but the rest of the audience are in like a totally different portal.
Oh. Okay, so what do you recommend I do?
I just sent you a Zoom link just a second ago. You should receive it. And that'll be a link to one of the breakout rooms.
I'll wait for that. Do you know which one? Like, can I pick one? Like, do you have a list of all of them?
I do have a list, but I just sent you the link for one.
But I know, Matt. Can you do you know them all? Or do you know the names of them? Because like I just want to go to a random breakout room. It's just not worth my time, right? So if I could know which ones they are, that will help me.
Sure. So the
If you
breakout
don't,
rooms,
it's okay.
I do have all of the links. I can send them all to you. There's no topics or anything. It's so the way that the breakout rooms worked is that they took the attendees, which there's about 200 of, they split them into 20 for each breakout room, and then they just assigned people to them. So there's no topics or anything to
Oh, there's
join.
no topics?
No.
Okay. I'll just go to that one that you sent me. That's fine. Yeah. Thanks, Matt. So I guess I should leave this session here, right?
Yep.
Okay.
Just meeting
Thanks.
here anyway. Okay.